I'd like to welcome everybody to a joint production of Rochester Lifestyle Medicine Institute and IHA in Ann Arbor, Michigan, Lifestyle Medicine Grand Rounds. Tonight's topic is how to keep a kidney transplant, integrating obesity medicine and lifestyle medicine for optimal treatment outcomes. Our agenda for tonight, I'm going to spend 5 minutes just introducing everybody, and then we'll have a case presentation and panel discussions. And then we're going to have Q&A for 15 minutes toward the end, and that'll take us to about 8:30 Eastern time. And then we've added a new feature because oftentimes when we have to go, because we like to respect people's time, so we like to let people go at the 1 hour mark, and you will qualify for a CME. You'll get your credit if you stay till 8:30. But there's often conversation that's I end up having to interrupt, which is kind of a shame because sometimes things get pretty lively. So we're going to move into the lobby, as we call it. Well, you don't have to do anything, but that'll be another 15 minutes or so. Thanks to a generous donation, all of our CMEs are free, including the one that you're participating in now. You'll be getting a survey at the end of this session, and if you fill out the survey, we will send you your certificate. We also have several other CME programs. If you go to our website, you can see what they're like. But one of the things that's unique about our CME programs is you can actually be, it's live participation with patients and people who are actually going through as for therapy. So that's unique. We ask that you consider partnering with us. If you're interested in partnering with us, contact Brian Bell at rocklifemed.org for more information. Let me just introduce our guest panelist, Tom Campbell, who is a board-certified family physician and a certified diplomat of the American Board of Obesity Medicine. He is founder and co-director of the University of Rochester Medicine / Highland Hospital Nutrition and Medicine Research Center, where he conducts trials to study the effects of comprehensive dietary change, with a focus on plant-based nutrition, on outcomes related to various diseases. And Dr. Campbell has extensive experience working with individuals and groups to prevent and treat chronic conditions using diet and lifestyle. He has authored or co-authored 2 popular books on nutrition, including the China Study, which was a worldwide bestseller, and has presented widely on the topic of nutrition for optimum health. Megan Grega is board certified in both family medicine and lifestyle medicine. She is the co-founder and chief medical officer of Kellen Foundation, managing director of L'Entressant, she'll have to tell me how to pronounce that, Retreat and Wellness Center, and she serves as faculty for the St. Luke's University Health Network Family Medicine and Internal Medicine Residency Program, implementing the Lifestyle Medicine Residency Curriculum, and clinical assistant professor in the Department of Family and Community Medicine for the Lewis Katz School of Medicine at Temple University. Dr. Grega is the conference chair for the American College of Lifestyle Medicine annual meeting. This year, I didn't know that, in Orlando. So if you want to see more of Megan, please come to the ACLM conference in November. She hopes to see you there. And let me get the next slide here. Deepa Sannidhi is our presenter tonight. She's associate professor in the Division of Family Medicine at UC San Diego, Department of Family Medicine and Public Health, where she teaches public health students, medical students, and residents in preventive medicine and family medicine. She is board certified in family medicine, obesity medicine, and lifestyle medicine, and trained in preventive medicine. She is past secretary on the board of the American College of Lifestyle Medicine and currently the chair of the research committee. She advocates for systems change that allows clinicians to practice in alignment with their values and help patients prevent and reverse disease via behavioral and lifestyle change. Her main areas of research are clinical models addressing high healthcare utilizers and obesity, and behavioral change in lifestyle. Dr. Sannidhi has co-created curriculum for the UCSD Preventive Medicine residency. And I'm gonna skip myself. You can see it right there. And right now we're gonna turn it over to Dr. Sannidhi and her fascinating case. So thank you all for joining us. If you want to put your location into the chat, we'd love to see that. Dr. Grega and Dr. Campbell could also turn on the video. That would be great. Thank you and welcome.
Well, it's so wonderful to be here with Rochester Lifestyle Medicine Institute. My talk is titled How to Keep a Kidney Transplant, Integrating Obesity Medicine and Lifestyle Medicine for Optimal Treatment Outcomes. Thank you so much for that wonderful introduction. I have no conflicts of interest to disclose, and here are learning objectives. The idea is really to get familiar with, how lifestyle medicine and obesity medicine can interact, and what can we really expect from lifestyle programs according to the evidence so far. So I'll start with my case presentation. So My patient here was a 42-year-old male with past medical history of prediabetes, end-stage renal disease, status post-transplant, hypertension, presenting with a chief complaint of, I want to lose weight. And so when we ask him why now, why did you want to pursue weight loss now? And why isn't a great question for motivational interviewing, but I do ask it because I want to understand what's bringing them in. He states that he feels short of breath even when walking a few steps and has been passing out trying to tie his shoes. For the past couple weeks, he has even been wheezing, although not really sharing any symptoms of leg swelling or other symptoms of what might be heart failure. So at this point, I usually start my weight history and my lifestyle history. And I'd love to ask the panelists, Dr. Grega and Dr. Campbell, what are some lifestyle and weight history questions that you might typically ask?
Well, I usually have a long conversation with people to start. It's one of these things why we have long visits, but generally, the weight history is important. So I like to think of it, I don't have sort of a rote list of questions, but I just like to understand the trajectory of their weight over time. So when did weight start being a problem? What have they tried in the past to counter this problem? How did it go? How much weight did you lose with each attempt? And then what's been your maximum weight? And when was that? So you have a sense of the trajectory, both in terms of severity, in terms of effort, and also in terms of time and duration. And just kind of going through that history and that trajectory gives you a lot of insight into previous attempts and what went wrong and what went well, what are their diet and lifestyle habits, and what things got in their way. And that can be a fairly long part of the history. I also like to ask a lot of other things beyond the weight history, of course. But I think of the weight history of just sort of understanding the trajectory, understanding the curve of, if you imagine sort of the weight over time over their life, and what things affected it.
Mm-hmm. And I would absolutely agree with Dr. Campbell that from the weight history questions, that these are very long visits to get an idea of what's going on in a patient's history. From the lifestyle standpoint, I like to ask patients to walk me through like a typical day for them or a typical week and what is going on as far as their food, their sleep, their physical activity, what sort of things are going on with their stressors, who's their social connection, all of those sorts of things, which I think Dr. Campbell was alluding to. There's a whole lot of different pieces that you would ask about. And so you're really trying to get a sense of what has worked for this patient in the past and what are the blocks that they need a little bit of help overcoming or coming up with solutions to. And one of my favorite questions that I think Dr. Sannidhi has also talked about in the past is from a self-efficacy standpoint, asking how important is it for you to change whatever SMART goal or whatever lifestyle habit you're talking about. So how important on a scale of 1 to 10, and how confident are you that you would be able to make these changes? Because that gives you an idea where your starting point is.
Yeah.
Great. By the way, there's a great question in the chat, and I promise we'll get to that at the Q&A, because so Annalisa, if you could put that, we might ask you to put that back in the chat later. But Deepa, proceed, please.
All right. Well, I'm just so curious about what Dr. Campbell's questions are, the extra ones. I don't know if we're going to end up with, if there's too many to state, but.
Yeah, I mean, I just like to understand, it's kind of like what Megan was saying, what Dr. Grega was saying, is just understanding their life around this issue. So this issue doesn't exist in a vacuum. It's integrated into everything else. So, who do they live with? Who does the shopping? Who does the cooking? What do you do for work? And then, of course, all the medical history questions, because so many times when I counsel people on weight loss, despite weight loss being such a popular, if I had to guess, it's probably the #1 cause for people to adjust their lifestyle. But, most of the time people take that extra step of seeing a doctor or specialist only because there's a lot of ancillary issues related to their health. I mean, this is becoming more than just a number on a scale. It's their function, it's their future, it's their another medication being thrown at them. And so understanding all of that medical history too is important. And it has ramifications for, how you would offer education or a prescription down the visit.
Dr. Sannidhi? Oh, she's I'm just. Oh,
We had a 5-year-old enter the room here.
okay.
For
Sorry.
a second.
Dr. Sannidhi, I'm just curious about what was the cause of the patient's renal failure. Was it the hypertension? It was just pre-diabetes, right? Or do we know?
It was actually, he was 22 and he had some obstructive uropathy. And so it was just sort of a tragedy of, maybe I didn't get into, exactly what caused the obstructive uropathy. It could have been just nephrolithiasis, who knows, but it just was this really tragic, fluke event.
Got it.
And so, actually his weight gain happened after that. When he was 22, he developed a end-stage renal disease from the obstructive uropathy and then gained weight after.
Unusual.
Although, I think Tom and Megan and I are really on the same page about, sort of this trajectory. And I think also sort of the bread and butter lifestyle questions, like what I think of like the lifestyle basics, we always want to ask all of those things. I start with, how old were you when you started struggling with your weight? And people typically will say things like childhood, my earliest was 3 months old, was when I first started struggling with my weight. And, and we talked about what are his life event triggers. Sometimes it can be pregnancy, sometimes it can be a hospitalization, sometimes it can be, a move, a job, things like that. And for him, it was his 2 renal transplants. It was harder to lose weight because he was recovering from surgery, but also, his family influences were his mother, who had always done well on a low carb diet. And so he just didn't know what to eat. And so, because he couldn't eat a low carb diet with a kidney transplant, he had to preserve his kidney, and he couldn't eat such high protein levels. And also then the COVID-19 pandemic, and then he developed a herniated disc. So he became very sedentary. So all of those things sort of compounded. And then I also asked very specifically about, have you ever been through any other medically supervised programs, any weight medications, any supplements for weight loss, any meal replacement programs, things like, and he had, he did try Herbalife and Atkins shakes, and those caused his protein levels to skyrocket, he said. And I also asked about disordered eating and binge eating and purging and restriction specifically, because that is not only a contraindication for weight loss medication, but also for, a very strict diet. And so then I take a very different approach when someone has an eating disorder history, depending on. And then I asked him his nutrition history. So, his mom he called an Atkins success story, and she had done well on Atkins in the past. He had tried a vegan diet briefly after having had the renal transplants, but wasn't able to stick to it. He said he didn't like the food. He's a chef by training, interestingly, so he likes to cook. And now he works as administrator for Caltrans, which is the transportation agency in California. And, my typical nutrition history, I ask things like, what are your food triggers? What is your fast food frequency? And then I specifically ask about restaurants and takeout, specifically, why do you eat out? And do you have any night eating, any snacking? What's sort of that weakest link for you? Do you do any mindless eating, the kind of TV eating, work eating, phone eating? And then I do a 3-day food diary. So this is his 3-day food diary. And I'll note that he actually did start to change his diet by the time he came to see me, which is fairly typical. And so you can see, he's got quite a bit of bread and turkey and cheese and hard-boiled eggs and Nature Valley bars. So that's day 2. He's got the Granny Smith apple in there and a Chinese chicken salad. And the chef salad, and the Carb Smart tortillas there. And then I ask about lifestyle pillars. So sleep. So he has a CPAP from sleep apnea, but his CPAP isn't working right now, so he's not sleeping very well. But no other sleep issues. I'll ask like, how many hours do you sleep? How's your sleep quality? Do you wake up feeling refreshed? And all of those things were okay as long as he had a CPAP. He was a 15-year former pack year. Smoking history, no longer a smoker, and he said sober since 2010. I'm not exactly sure what that means. I didn't actually delve into that. I probably, I should have, I would say, but he's certainly not struggling with alcohol use anymore. And his social connectedness, he's not currently sexually active. His mom is a major support. He doesn't have, and he has a good friend group. He saw me in a video visit, and typically I do a bunch of paper questionnaires. So there were a bunch of questions that we didn't actually get done. In an in-person visit that I typically do. But when I asked him about his stress and his mental health, he said, overall good, considering everything. And that kind of exemplifies him. He's a kind of a really great attitude about everything. But these are questionnaires that I typically do in my assessments. And then his past medical history. So really these are the highlights. But his end-stage renal disease was because of an obstructive uropathy. And then his first transplant started to fail after 10 years. So then he had another one, and he wanted to really keep this one. And then these are his medications. So, immunosuppressants, including prednisone, and then antihypertensives are sort of the highlights there. He had a DVT from after an episode of thrombotic thrombocytopenia, and so then was on Coumadin, now on Eliquis. And he has and then these are his review of systems. So snoring, lack of energy, daytime sleepiness, dyspnea on exertion. We didn't do a PHQ-9 or a GAD-7, but he did note that some depression and anxiety on his review of systems, despite saying that overall his mental health is pretty good. So on physical exam, this is a video exam. So, his self-reported weight was 284, and his blood pressures were 143/92 and 144/78. And then here we have some recent vitals with a normal, which were normal. And then his video assessment was pretty normal. And here are his labs that were done a month before I saw him. And so his creatinine was 1.79 with a GFR in the low 40s. This is his hemoglobin. He has a little bit of leukocytosis here. His A1C was 5.9. He's on Lipitor. And these are his lipids on Lipitor. And then he has a high parathyroid hormone, for which he's on calcitriol. And so here's some labs. So this is sort of a creatinine trend from 1.67 in February of 2020 to August of 2021. His creatinine was starting to creep up a little bit to 1.79. And so we can say at this point that his initial assessment is class 3 obesity with weight-related comorbidities, including prediabetes, hypertension, hyperlipidemia, and the management of which is complicated by end-stage renal disease on immunosuppressive medication, which is code for also, obesogenic medication, because he's on prednisone. And so, part of my assessment, I calculate an adjusted body weight, and I use a calculator. There's multiple calculators available. I use the one by Global RPH, which is like a pharmacy website. And and the reason I do an adjusted body weight is that, what I tell patients is that you're looking for the weight, that ideal weight that you would have been, but also taking into account the skin and connective tissue that you gained once you had gotten to a maximum weight. So I use their highest weight to calculate that adjusted body weight. And then I calculate what's realistic as far as weight loss. And so I'd love to actually hear, I have what I typically say, but I'd love to hear from our panelists, what they counsel patients on as far as, what can they expect with weight loss.
Dr. Campbell, you're unmuted, so we'll give it to you first.
Yeah, you know what? It's kind of interesting. Different people have different approaches. I ask the patient what their goal is and let the conversation flow from that. And sometimes people will have realistic expectations where they'll say, my first goal is to lose 15 pounds and get below 200 or whatever the mark is. But they'll say, but ultimately I'd like to lose 60 pounds. And then other times people will say, well, I'd like to lose 40% of my body weight, and that's their first goal. And some people react differently to that. If somebody says their goal is sort of too high, I don't have a problem with people making extravagant goals, but I do feel it's very important to help them understand the context of what they're trying to achieve. So if they want to lose 30% of their body weight, great. That it's not going to happen for most people, but having a conversation about how that fits into expectations, is that realistic? Like, how many people achieve that? If you look at people who are sitting in a doctor's office interested in weight loss, how many people lose 30% of their body weight? It's not much. So I have no problem with that goal, but realize, that's going to demand some extraordinary effort. And even along the way, if you get part of the way, you're going to achieve wonderful things for your metabolism and health and other outcomes. So there's no really right goal. It's more about, I think, people understanding what's realistic and achievable, and how strict they're going to have to be to have the big losses.
Yeah, Dr. Grega.
I would agree with Dr. Campbell that the key is to find out what is the patient hoping to get out of this, what are their goals, but then to provide some context. So what I usually say to people is ask them, what is it that they're looking for as far as their weight loss goals? However, then tell them that looking at 5 to 10% weight loss for their body weight is going to be so helpful for whatever chronic diseases they already currently have. So telling them like, hey, this is really going to help your blood sugar, or it's really going to help your blood pressure. So let's focus our first goal on that 5 to 10% body weight. And then you figure out how much that would be. So if you say 10% and you say, okay, with somebody who is, 250 pounds, so 25 pounds. Okay, so how long might it take to lose that weight in a realistic way so that people aren't like, well, I'm going to a wedding 2 weeks from now and I want to be 20 pounds down, because, that's probably not going to work. But say, okay, let's say if you're losing maybe 1 pound to 2 pounds a week, you might lose a little bit more. Weight loss is not a straight down slope. You kind of plateau and maybe go up a little bit, go back down. But then once you reach that first goal, that 5 to 10%, whatever you're looking at, then make a new goal and keep working and say, we can do this for a long time. Weight loss took a long time to put the weight on, takes a long time to take the weight off. And even if you never get past 5 to 10% of your body weight down, you're still going to get a lot of metabolic benefit. But I'm happy to keep working with you, and like wherever your goal is, we should be able to find a way to get there. It may just take a lot longer. Now, like Dr. Campbell said, if the goal is a 40% body weight loss, that may be a little bit unrealistic. But I agree, we don't want to squash anybody's goals. We just want to give them an idea that it's going to take a while to get there, and for it to be something that is sustainable and lasts. You can't do it overnight. You can't do it in 2 weeks. It's going to take a while.
Yeah. Yeah, I love that. I think it's good to contextualize, understand what that mean is, and not with the idea that somebody might fall below that mean and, very far above that mean, and, and that's okay. But regardless, they're going to have those metabolic benefits. And, I really love that concept of, talking to people about how this is a journey. And I actually have a slide, Megan, of how, saying it's not a race, it's not a marathon, it's a lifelong journey that I found somewhere. Because it really is that. And I think it's just support and helping them understand that it's supporting them through that, through life's ups and downs. So I, I calculate this adjusted body weight, and I say, so that's what was physically possible. And then we have what's neurobiologically, seen in research studies. And, I do talk to them about hypothalamic set points. And, I think it's interesting, because in the lifestyle medicine world, we don't talk about those as much. But I like to talk about it because I think it helps them understand when they're struggling, why they're struggling. And so, when we get to a certain weight, we develop that set point, and our body starts to, it starts to suppress our activity in very subtle subconscious ways, and it also increases our hunger in very subtle subconscious ways. And so, we might have a particular diet, but then we, eat mindlessly, because of that hunger, or we might, things like that. And so, and so finding lifestyle way, and then I talk about lifestyle ways to address that set point, which, are not discussed enough, I think, of fiber and water and whatnot. But, with medications, that projection can go up to 15%. So, I sort of contextualize the whole picture for them. And so, it can be really hard to lose weight and even keep it off. This is sort of a meta-analysis by Franz et al. From 2007, looking at different, sort of that average mean of different modalities, looking at different lifestyle modalities. And so this is advice alone. And here's exercise alone. And then here's diet plus exercise. So, I think that's, this is like in kilos. So about, 12 pounds on average, which actually does make sense. I mean, most people are somewhere in that 200-pound range that end up in these studies. And then, so about 10 pounds, 12 pounds is about 5% weight loss. And then there's some weight regain, but not all of it. And then you have, very low calorie diets work the best. But then you do have that weight regain as well, in the long term. So here's sort of some of the classic studies, the diabetes prevention program that many of you know, or if you haven't, I would highly recommend you look it up. It's one of the classic studies, 6% weight loss on that one. This is Look Ahead study, in which they did actually lifestyle plus medication. They had different arms, but intensive lifestyle intervention was 4.7%. Pounds lost study looked at different types of diets, and on average found a 4% weight loss. So overall, we say that clinically meaningful weight loss is 5 to 10%. And United States Preventive Services Task Force also backs us up on this. So they say that we want to have a intensive lifestyle intervention. Anyone with a BMI of 30 or above should be referred to an intensive multi-component behavioral intervention with more than 5% weight loss, more than 12 sessions in the first year, with lots of different kinds of behavioral interventions like identifying barriers, self-monitoring, peer support, relapse prevention, things like that. So so obviously the range of recommendations is certainly broad, but I'm curious from the panel, what are some recommendations we would like to provide at this time?
Dr. Grego, would you like to take that one?
Sure, absolutely. Well, there's a couple of things that I'm worried about with this gentleman to begin with. So his kidney function being one of the main ones. And so diet is going to be a big intervention for anybody with weight loss, but in this gentleman especially, because his choices of his food is going to make a big impact on his kidney function. So I would really want to start talking to him about the importance of plant protein instead of animal protein as much as possible, increasing fiber. He was already drinking a lot of water based on what your 3-day diary looks like. But one of the recommendations is to start shifting to a more whole food plant-based diet. We could definitely get into physical activity as well, because those two complementary should help him kind of kickstart his weight loss. Then there's other things going on, like his CPAP is no longer working apparently, and that's not going to be a good thing as far as weight loss is concerned. So that's one. And one of the things that I think is going to be a challenge is the fact that his family, especially his mom, is eating more of an Atkins type diet. So there'd have to be a lot of discussions about. One of the things I think is most important for patients and for us too is what are the social norms that we are surrounded by. So what all the people around us are doing, we are more likely to be doing. if his support group is mostly eating a, very Atkins type or low carb diet, it's going to be difficult for him to shift. So talking about how he can maybe start bringing some of that type of food to the family gatherings. When I say that type, I mean like more whole food, plant-based, teaching him things like lentil loaf instead of meatloaf, or, that's just one example. But also seeing if you can hook them up with a group that is a whole food, plant-based, either support group, cooking classes, things like that, so that he can start to get some ideas. So that's just a very beginning, skimming the wave tops. But diet and exercise are the first two things I've talked to, and asking him to get his CPAP fixed.
Mhm. Thank you for that, Dr. Grega. Dr. Campbell.
Yeah, I would echo all of that. I think the low carb aspect provides an interesting angle. So there's two sort of unique things about this case that would differentiate the conversation maybe from other weight loss conversations. One is the kidney disease, and the other is the low carb aspect. And obviously, other people have those things, but in this case, I would sort of start by asking him what is your, so what if you started today on your own before coming to me, what would be your strategy for losing weight? So that, as a question to understand, where people are thinking about going. So before I open my mouth about recommendations, see what would you recommend for yourself? And in this gentleman's case, I suspect, based on my experience, that with people who have really only done low carb in the past seriously, and with a mom who's done low carb, there would be quite a lot of education about what food is okay. And I noticed in his 3-day food diary, for example, that there weren't really any starches, if I remember correctly. I think there was a sandwich which presumably had bread. But I think there were wraps, the carb smart wraps, and otherwise it was like meat and cheese, carb smart, and and that was pretty much it. So the idea of moving, so you have someone with kidney disease that you're educating, plant protein instead of animal protein, but you have to do it in a sustainable way. And so I saw there's oftentimes this patient falls in the category of people who are set up for a trap, where they may be enthusiastic and they do the plant-based thing, but it's going to be the salad diet. It's tons of vegetables. Okay, I'll do some rice, Campbell, but it's going to be half a cup of rice, when you ask them later. And so just a little bit of education about what food is consistent, the details of what foods would be okay, and the starches, because the starches really need to be, if they do that plant-based low carb thing, more often than not, they're going to be starving to death, and it's going to be hard to sustain. So doing a little bit of education about plant-based diets and kidney disease, and specifically asking about starches and perceptions of starches, and what you might need to explain or educate there, and then absolutely, Dr. Grega said that all the resources that you can pull out as you get into that conversation, if there's any group resources, anything with ongoing support and accountability. And more detailed education is really going to be valuable.
That's such a great point about the starches. Sorry, Ted. Yeah, it sounded like you were going to ask a question.
Well, I was actually going to talk about the starches also. So, Tom, could you just, what would you recommend when someone says, I'm afraid of starches? How do you educate them about that?
Well, it's a little bit of a leap of, that it can be a little bit of a tense moment, I suppose, after you've been, eliciting their story for so long, because basically what I'm about to say is at odds with maybe what they have strongly felt for years, which is that potatoes and rice are going to kill me. So it's just sort of easing into that conversation and saying, talk in the context of a plant-based diet, and then say, if you really have to have the starches to stay full, because vegetables don't have the calories, and they're wonderful and healthy, and I want you to eat a lot of them, but we have to start easing, and there's just going to be a period, where you try it out, and you give it this is I always frame these recommendations as much as possible as thinking about a short-term experiment, really short-term. Let's think about doing this next thing for 2 weeks and see how it goes. And and if somebody is motivated enough to make a special doctor visit and go through all the rigmarole of that, and a 2-week experiment usually is a soft enough entry to allow that. Occasionally people quickly say, no, I don't want to do that. But if you're talking with people who are very motivated, if you're a primary care provider and you're having a very brief conversation, that can be a very difficult moment because you don't have enough time.
Right.
I would jump in with this particular patient. If they went from what they're currently eating, which is not very much fiber, and go to a completely whole food plant-based diet overnight, they're probably going to be very uncomfortable with bloating and constant, like GI issues. So, and then they may not want to continue. So this particular patient, I would not say, hey, that's it, no more cheese, hard-boiled eggs, turkey, at all, but to start transitioning them to a different breakfast would probably be one of the first ones that I would start with, and adding more fiber. So they maybe it is a salad plus some a potato or some beans, or adding some beans to their salad, but not getting them 100% whole food plant-based right away, because that seems to be, at least in my experience with patients, they have so much discomfort that a lot of times that they are not willing to continue. Whereas if you add the fiber over a couple of weeks, or 2 weeks, something like that, it's more easily tolerated, so people are more likely to continue it.
Interesting. All right, Dr.
I'm
Sannidhi.
laughing.
Yeah.
Oh no, I'm just laughing because when Tom was talking about the that tense moment, I just had this memory of a patient actually when I was doing primary care, and I said to her, maybe trying out a plant-based diet because you've always done this low carb thing. And she was like, gosh, it was just something she identified with. And she was telling me how she made, like, just yesterday I made chaffles, which are like cheese waffles, cheese in a waffle iron. It's like, so yeah, so intense moments, definitely. But I'll just share that, one of the things that I find goes over well, talking about rather than the grains, like talking about potatoes and sweet potatoes, and how like a potato is just a totally different food than, than mashed potatoes, the way you normally think about them. It's kind of like almost the difference between a whole grain and and white flour, like a wheat berry and white flour. It's that seems to go over somewhat well for people sometimes. But
one random tidbit that I thought of, Dr. Greg, I totally agree, getting the CPAP fix, because it could help his daytime somnolence and energy and help him feel better and be good for his health overall. But interestingly, studies reveal with regard to weight that when people start CPAP, they gain weight. It's totally counterintuitive, because poor sleep is a risk factor for weight gain. But when people start CPAP, they oftentimes gain weight. I don't know why. I have my own hypotheses, but it's just a point of interest in this case.
Yeah. I've been made aware of that data as well. And I mean, although I've had people lose weight on after starting their CPAP. And I think it's, I wonder sometimes if it's just that, like, we catch them at the right time. And so, maybe they would have gained weight, but then we help them lose weight. So,
well, my own hypothesis, and it's totally just made up in my privacy of my own brain, but is that people, if they start CPAP and they sleep better, their nighttime energy expenditure may decrease a little bit, but, they've had decades of eating patterns. And when they start CPAP, nobody ever told them, wait, you're going to be burning a few less calories, so you better watch your food. And so they continue their same eating patterns, but they burn a slightly fewer calories. And that's my own, who knows, that's probably.
Makes sense. Anyway, so So here's my initial plan. So from a lifestyle perspective, I provided, because he was a chef, I provided him some neat little resources on how to make healthy plant-based food, like the Big Switch and PCRM 21-day Kickstart, and told him to look at the videos and the Ruby Forks Over Knives course. But probably what was even more effective was, I think because I thought he was a chef, he would want to do all this cooking, but really he's like this guy who's tired and, is an administrator and, who doesn't really want to cook a whole bunch. And, he actually had been avoiding fruit and loved fruit, and was, just smiled from ear to ear when I told him he could have as much fruit as he wanted. And so that actually made a much bigger difference. And then I did start him on medication. So I started him on liraglutide, which was covered by his insurance. And I titrated him up to 3 milligrams daily. And why did I do that? Because, he's on multiple obesogenic meds that, like, including the prednisone and the gabapentin and the Cellcept. And despite his best intentions, was really struggling with, for example, too many low carb cookies. And also, we didn't, my concern was that we didn't have as much time as it would take to maybe go on the lifelong weight loss journey that we talked about. The hypoglycemia, often we don't necessarily always completely reverse the hypoglycemia. And in his case, the hyperglycemia, or reverse the hyperglycemia, with lifestyle intervention, we can a lot of times get people into diabetes remission. He has pre-diabetes. We can get him back into the normal range, but I was eager to get him into the normal range because I wanted to keep his kidneys in good working order. And so, I thought I'd share some information about how high intensity lifestyle interventions and pharmacotherapy combined can be really quite helpful. And also just comparing medications and high intensity and intensive lifestyle intervention. So, these are some of the studies that we talked about, the look ahead and DPP, and then, I think this might be pounds lost, I'm not sure. And these are many of the medications. So phentermine topiramate actually had the best data prior to, Wegovy, which is semaglutide 2.4 milligrams, and tirzepatide now, which is Mounjaro. Those have higher weight loss, but phentermine topiramate had the best. But you can see here, up until phentermine topiramate, really lifestyle intervention and weight loss medications were pretty much head to head. They were equal, in my opinion, equally effective based on this data. But if you combine lifestyle intervention with medication, you get some really good results. So this is a study, kind of old study now, 2005, but this was sibutramine. We don't use sibutramine alone anymore. It's been recalled. But sibutramine alone, you saw about 4 kilos weight loss. Lifestyle modification alone and a behavioral intervention alone, you gave you about 6 to 8 kilos weight loss. Combined, though, we got up to 12 kilos at 52 weeks, which is pretty fantastic. And then this is a meta-analysis of different lifestyle interventions and medical therapies and surgeries. And you can see, so this is medical therapy and lifestyle intervention. So if the key up here is the blue is more than 5% weight loss, the green is more than 10% weight loss, the purple is more than 15% weight loss, the orange is more than 25% weight loss, and the yellow is more than 35% weight loss. So, this is the percentage of people who got to 5 to 10% weight loss, but and this is the percentage of people who got to more than 10% weight loss in medical therapy plus lifestyle intervention. Then if you look at medical therapy plus intensive lifestyle intervention, you start to see some people getting into that 15% range. And you start to see some people even in the 25% to 35% weight loss range. And here is medical therapy plus lifestyle intervention again. So we see some better results in this particular one. So, we put him in our patient in a lifestyle intervention that was based on shared medical appointments with 90-minute group visits, including all the components of behavioral therapy for obesity. And I wish I had enough time to go into every single one of these. It's fun. And our program is called Supervised Lifestyle and Integrative Medicine for the Treatment of Obesity, and sort of our structure. And these are our curricular components, which are really all the 6 lifestyle medicine pillars. But I also wanted to share that I would say positive psychology has been a game changer for us. And we originally had it somewhere, week 13 or something like that. And we moved it very quickly to week 3. So that's been really helpful. And here's our course. So, here is his original weight in September of 21 at 284. And he's been maintaining just around 218, 215, things like that. And so his adjusted body weight, I'll remind you, was 213. So he got to that adjusted body, very close to that adjusted body weight, which is pretty amazing. And, and his expected would have been 256 to 270 with lifestyle alone. With medication, that would have got him to 242 if we were just going based on the mean. So this is a perfect example of, how he beat out lifestyle and medication together, and you never know where people can end up if you give them the tools. His blood pressures were 143 over 92, got down to 100 over 63. We had to cut his nifedipine. His nephrologist cut it down to 30, and then we ended up at 129 over 87. His creatinine trended down from 1.79 to 1.58 in my recent appointment with him, which is the lowest it had been since 2016. And he still keeps in touch with his group mates. He no longer needs a CPAP. He exercises frequently until he recently picked up his girlfriend and put her on the counter and ended up with a ventral hernia that put him in the ER. So it was reducible. He was able to, he's scheduled for surgery, but he can't exercise until then. But he has a girlfriend, which he didn't have before. And his girlfriend is very supportive. She's a personal trainer and has just been wonderful for him. He still keeps in touch with his group mates. And something that's sort of bittersweet is that, his father passed away actually about a month ago, and he fell off track because of, naturally, but he actually got back on track in just a week or two because his girlfriend was so supportive. His group members helped him get back on track. Some of the older women said, do you want me to come over there? And so he got back on track, which is amazing. His OSA is completely reversed. And I mentioned he had some depression and anxiety. We didn't assess for it earlier on, but his perceived stress scale now showed very low stress with a score of 7 over 40. This is his NHANES fat screener, and this is the fiber screener over here. So, definitely could be better, but, getting there. So it's a journey. And part of it is actually he had slipped by the time he saw me. So things were getting better. And he was still sort of in the process of getting back on track after his father passed away. And so same here, definitely still more fat than I would like, but moving in the right direction. And then here are some of the assessments that we did finally when he came to see me in person. So this is the PROMIS 10, which is the Global Quality of Life, multidimensional scale of social support, GAD-7, PHQ-9 for anxiety and depression, and then our 3-day recall. And so, so when counseling patients on weight loss, we want to do evidence-based counseling, and talk about what we can expect and what are, and sort of contextualize where they are, talk about how lifestyle, and we know, and hopefully I've shown you how behavioral therapy and medical therapy and lifestyle therapy can work synergistically to really improve results. And what you want is intensive lifestyle intervention. John Kelly often talks about how dose is very, very important. And so, intensive, frequent lifestyle intervention visits are important. So that's all, folks. Please feel free to direct any questions to me at this email address. And
Dr. Sannidhi, thank you so much. That was a great presentation. Dr. Campbell, you have any comments?
Nothing in particular. I just see it's a very nice case. Thanks, Deepa. I see some comments in the chat here.
Yeah, here's a question. Maybe we could have you. You could start with. Okay, how do you respond to those who pit lifestyle medicine and obesity medicine as dialectically opposed to each other? Dr. Campbell, I know you've got some experience with that.
Yeah, so I'm a diplomat of the of obesity medicine, like Deepa, and it's interesting. Just from a organizational point of view, they have low carb. It's kind of low carb. I don't know what you call it. The physician leaders tend to be the sort of leading low carb people, and ACLM, the physician leaders, tend to be the plant-based people. So there's maybe some difference in terms of how they approach things and their education and so forth. But gosh, there's an awful lot of intersection when it comes to treating patients and how to meet patients, where they are, how to understand patients, and motivational interviewing and all that stuff. So, if there's opposition, it's just from that low carb versus plant-based thing, I would suspect. But that's the world we live in.
Sure. Do you think the low carb people would be as emphatic in this particular case where we're dealing with kidney function?
No,
they would back off.
They'd probably find a way to stay pretty low carb in a kidney safe way. That would be my guess. Who knows? I don't know.
So here's the question that's for Dr. Grega. Dr. Grega, you mentioned it took a long time to put the weight on. It will take a long time to take it off. That's a quote from you. How do you respond to those with fairly rapid weight gain, like high normal to overweight, 20 to 30 pounds in a matter of months?
So in cases like that, it's actually usually easier to lose that weight if you start. So Deepa was talking about set points and how your body gets used to different weights. I would say if the weight went on rapidly, first of all, we got to find out why did that happen. So there's got to be a workup to find out, was it just a lifestyle change that happened, or is something else going on metabolically? But let's just say metabolically, life has not changed. It's just that you changed your eating habits, or became sedentary, you had an injury, whatever. I still would say that the safest way to take the weight off is 1 pound to 2 pounds a week, because you're more likely to sustain that weight loss. But I would say the good news is you're catching this early. And it's going to be easier for you to take this weight off than if you maintained a higher weight for a year or two and then started to try to take it off, because then you're getting more into the set points and things like that. So if somebody gained weight quickly, let's make sure there's not a metabolic reason why that happened. And then I still give the same advice of let's try to do 5 to 10% of your body weight, try to lose 1 pound to 2 a week, looking at your food and telling them that if you try to get it all off in the next month, it's going to be hard. You're basically asking your body, you're putting your body sometimes into more of a metabolic, your basal metabolic rate may go down, and you're also going to be fighting all the cravings of things. I mean, it depends on how you do it as well. But if it's only 20 to 30 pounds, it's not like you're going to put somebody on one of those really, really low energy diets that Deepa was talking about. You're really just asking them to change their eating habits and their exercise habits, so that over the next 20 to 30 pounds, so what would that be, about 8 pounds a month, give or take. So over 3 months, they should be able to take that weight back off again, which it sounds like was kind of how long it took for them to put it on, actually.
Right.
I would totally agree. Just one very small comment. In addition, if people are talking about really rapid changes over very short time frames, that's not a little different than the question, I think. But if people are talking about 10, 20 pounds over 10 pounds over weeks, a smaller number of weeks, it's really valuable to think about water weight too, and sometimes bring that up, because people oftentimes don't think about water weight and whether it's related to medications or I've noticed that some individuals, purely anecdotal, just have a propensity for big swings in water, and it's not from obvious heart failure or kidney patients. It's just otherwise healthy people sometimes they have a salty day and they've noticed these huge swings in water weight. And sometimes people get real confused about that. So just a tiny thought that I have.
Oh, that's an excellent point. And I'm really glad you brought that up, because I've had several patients that they go away on vacation and they come back a week later, 7 pounds up. And you're like, how did that happen? And a lot of it is because of the restaurant food or whatever they're doing that is much saltier. And it's not that they're in congestive failure or kidney failure. They just had a lot of salt.
Yeah. And people can get demoralized. And so, understanding there's water can be a valuable, consultation, a valuable intervention for them.
Well, thank you for that. We have a couple more minutes, and then we're going to go into overtime after that, into the lobby. But it looks like here's a question for Dr. Sannidhi. Please, well, where is it? Someone wants. Oh, here we go. Where can we find more information about SLIM? And is there a handout I can share with my team? And also, is this tailored to peds?
It's, I think you could fairly easily give extend it to adolescents. But I hesitate to say that it's we could do it in kids. I would need to kind of really think more about that before I said yes. But I'll share the website for my program in the chat here, and so you can see, kind of a detailed description. It is. We I'm not licensed in any other state outside of California, so it'd have to be, somebody in California that I'm seeing if you wanted to refer. But we are working on getting those materials on a website. So stay tuned. If you join the shared medical appointment discussion group in the American College of Lifestyle Medicine Connect platform, I'll be sharing, once we have everything up, I'll be sharing what our materials are, so that you can, and it'll be just available for download for free. PowerPoints, everything, speakers notes, we're getting set up.
That's wonderful, Deepa. That's awesome.
Yeah, fantastic. Okay, any closing remarks? How about from our guest panelist, Dr. Campbell? By the way, how's your practice going? I know you're seeing patients on telemedicine now, right?
Yeah, a tiny bit.
Okay.
Yeah, mostly doing my research, spending time with my family.
Okay, sounds good.
But research is exciting.
Yeah, great. Dr. Grega, any passing final remarks?
I think this is such a great case that Dr. Sannidhi gave us, and it really made me think when I was reviewing it about the kind of missed opportunities that this patient got to age 42 before he was able to access the type of care that Dr. Sannidhi's giving. And I'm not sure why his other kidney failed, but it's possible that some of his lifestyle choices at that point, if they had been addressed, maybe would have helped keep that kidney. So that made me think about how much money we are willing to pay in our healthcare system for things like a second kidney transplant. Or I looked up liraglutide, how much does that cost? It's like $35 a day if your insurance doesn't cover it. Yet we won't pay for medically tailored meals for somebody, which could be less than $35 a day. I mean, I totally understand why you needed to put him on it at this point, but at previous points in his trajectory, we could have intervened as a healthcare system in a much less costly way and much better for the patient. It's just that we don't prioritize those things. So that's one of my big things. I know with Kellen Foundation and with all the stuff that I do from a community level is we are paying a lot of money for things that only make sense to use when you're at this point where your BMI is 39, you're about to lose another kidney. We could be putting money into this and much earlier, and they would never get to this point.
Absolutely. Yeah.
Well, listen, it's 8:31. I'm going to make a couple quick announcement. Everybody who's attended this to the end will receive an email and with a survey, and just to say how you like the program or didn't like it. And once you fill that out, you'll get a certificate for an hour of CME in the mail from Rochester Lifestyle Medicine Institute and the Rochester Academy of Medicine. And having said that, we're going to go into our overtime. This is the first time we've ever done it. We're just going to walk out into the lobby, so I can relax. And anybody can disappear if they want. That includes our panelists or Sannidhi, but Dr. Sannidhi, but I'm sure I'm sure
I'm
people are
sticking
gonna stick
around.
because I think it could be interesting. All right, sounds good.
Yeah.
And
That's a good question here about high potassium foods.
Yeah.
okay.
Yeah.
You
And
know,
I actually debated between this one and in the case of somebody on dialysis that I have right now who's trying to get her kidney transplant. And I only, she saw one of the other weight loss doctors and did end up recently on tirzepatide. She was on, she had diabetes. But I would say it's, I started off kind of being like really careful in my recommendations, and then I just, her potassium went up, well, actually it wasn't her potassium, it was her phosphorus. And then I just said, just get your labs every week and then, watch the phosphorus and, just, it'll be fine. Like no one's gonna get hypoglycemia. Like a lot of people on dialysis just eat all kinds of stuff that they're not supposed to, and most of the time they're okay. Like none of us are strangers to the potassium of like 7. And I remember one time getting called with a critical potassium of like 6.9, and I called the patient and he was like, it's fine, that happens to me all the time.
Yeah, I see we have Dr. Paul Berkowitz in the audience, who's a nephrologist in Ann Arbor. Dr. Berkowitz, would you like to reveal yourself? And if you're still there, I know I see your little rectangle.
I am.
There he is. Okay, I know you're kind of shy. But...
Yeah, right. That's the first time I've been accused of that.
So,
but at any rate, I can tell you within the nephrology community as a whole, there's been a sea change in our thinking about diet, and we think that we have been doing a disservice to our patients with respect to the traditional advice that we're denying them incredibly healthful food products, that there's a very poor correlation between diet and actual potassium levels in the blood. And part of that might be because the plant-based diet that they eat tends to be an alkaline diet, which would mitigate some of the hyperkalemia. We think that, not allowing them to eat fruits and vegetables and the fiber that comes with it has adverse effects on the gut microbiome, increasing certain of the uremic toxins that evolve from the gut into all sulfate and our favorite TMAO and all those things. So there's been a huge change in our thinking, and we're going much more whole food plant-based. And you can actually go on the NKF site, which I would call a mainstream organization, and on their diet recommendations, there's a picture, a cart full of vegetables and fruits, and they're talking about evolving towards, fruits and vegetables. So I think that risk is overblown. The phosphate, again, is poorly absorbed when compared to processed foods and even meats because of the phytates that the phosphate's bound to is really poorly absorbed. So, ashing food and saying, it's got this much phosphate in it, is not really biologically relevant. And so we're coming around. Give us a little more time. We're getting there.
Yeah. Well, thank you for that. How would you differentiate between people who are close to going on dialysis and people who are already on dialysis?
I wouldn't. I tell them that, if it becomes a problem, we'll deal with it. With respect to the potassium, talk about expensive medications and all, but, with respect to the potassium, we now have effective oral potassium binding agents that you can start a patient on to try to control the K. And of course, there's always been oral phosphate binders, but we're definitely going, towards a much more healthy diet, and the restrictions that we used to apply are really fading.
Got it. Thank you for
Hey,
that.
Ted, can I jump in real fast? Hey, it's
Please.
Melissa.
Dr.
Hey,
Sunderman.
hi. I was supposed to be on the panel, and I had the privilege to spend the night at Dr. Barnett's house last night, making my way out to Canyon Ranch here in Massachusetts. Got a little busy. But I listened to it, a great case. And so, Paul, since I've got you on here, I was just getting my food from Canyon Ranch, which is fortunately very plant forward. and was talking to a guest who was recently diagnosed with FSGS. She doesn't know why she got it. And so I was talking up,
Can you explain to us what that
focal,
Focal and
segmental-
segmental glomerular sclerosis. It's a glomerular disease that usually presents with nephrotic syndrome.
Right. So she's nephrotic. So of course I was like, well, as far as I know, and I said, listen to this webinar right now. They've got some nephrologists on there. So is that something that even with nephrotic syndrome that whole food plant-based could be helpful for?
Yes, because usually we actually recommend low protein diets for these folks, which is, counterintuitive. Well, I'm losing all this protein in my urine. I must have to eat a lot of protein. That's not the case. They too should be low protein. And, there's a sentiment. I tell you, I have patients come in all the time and they all want to be on low protein diets because, there are reasons to think that proteins are. I said, don't worry about the amount of protein. You worry about the type of protein. And I said, you stick with plant protein and you'll be much better off. And that's what I tell them.
And then she was told to avoid sodium. Is that probably because of nephrotic syndrome, like hypertension or something like that? Or?
Yeah. Well, they have edema, so low sodium is generally recommended. But again, there's only one way I know of in America to be on a low sodium diet, and then that's whole food plant-based. Right. That's the only way that I know of. I mean, again, there's that misapprehension by our patients. Understandable. Well, I took the salt shaker off the table. I said, well, that's great, but so.
Right.
So any other comments or questions that while we're all together, and we can ask this.
Asked a question about fruit and sugar, and Deepa put a good link in. I'm not sure which study you linked to, Deepa, but about the biochemistry person who said that fruit is just like straight sugar. And when I talk to people about fruit, I talk to them about the fiber in the fruit, and that, yes, there is a lot of sugar in fruit, but that the universe took what we might think of as the poison, the sugar, and wrapped it in the antidote, which is the fiber. And as long as you're eating the whole fruit, you're really slowly letting go of that sugar. And so it's not like shooting your blood sugar up. And I talk about the study with the berries and how berries really, I'm trying to remember which study that is. I always have to pull it back up, but where if you eat some white rice or some white bread and you follow where the blood sugar goes, you spike like you would expect and then come down. If you have the same amount of white bread or white rice and a cup of berries, you get a lower sugar spike in your blood, even though you put more carbs in your body, because the fiber in the berries is holding on. Not only is it holding on to its own sugars, it's holding on to some of the simple carbs that you would have been getting from the white rice or the bread. So fruit juice, that's a totally different thing. But if you're eating your fruit, the sugars are being released slowly enough that it's not like having a straight sugar. Would you say anything differently, Deepa or Tom? Or
No, yeah, I would agree with that. And I just kind of talk about how it's like a matrix that's kind of trapping the sugar in there, and it just, takes time. And, it's like, it's similar to like our, in our intestines, if you put that fruit in some water, it would take so long for the water to become sweet. And it's the same in our intestines. The enzymes just have so much more trouble getting the sugar out from that encased fiber, that fiber encasement. But the study was about
I don't know if that's the one that you put in, but there's also a study with diabetics where they took two diabetics and put them in two groups, and they told one group you should have no more than 2 pieces of fruit a day, and the other group they said have at least 2, but try to have as many pieces of fruit or servings of fruit as you possibly can. And they followed their blood sugars, and there was no difference in their blood sugar or their A1Cs between the two groups, as long as it was whole fruit, not like apple pie or a fruit juice.
Mm-hmm. Yeah, I mean, that's I would love to see that citation. That's not what I posted, but I usually, I mean, I don't know if it would help with this person, but I usually talk about how like there's literally no agency, there's no organization that's authoritative that says that you shouldn't have fruit for diabetes. Every single one of them thinks that fruit is, there's no evidence really, that's conclusive that suggests that fruit is bad for diabetes. And I just can't find any. So if you can find me some, then that's great, but can't find any.
And yet that's always the question. We always get that question with our groups. Like, I can
Yeah.
have fruit, really? But I have, or they'll put in, well, I understand what you're saying, Dr. Barnett, but I have diabetes, so I'm one of those people who can't have fruit. So we still here. Yeah. Well, this was great. Thank you everybody for sticking around in the lobby afterwards. Please tell your friends about this. We do this every month. So,
Just said,
yeah.
can I invite my LMIGs to attend these events? And yes, I do that with my LMIG all the time.
Yeah,
So-
sure. Absolutely. Please do that. Yeah. Yeah. Let people know. And because I think these conversations afterwards are really kind of fun. And I noticed that Dr. Tom Campbell is in the audience, and I believe he's the one who actually coined the term whole food plant-based. Is that correct? Anyway, maybe Tom, I'm not sure you heard, but I'm pretty
Yeah,
sure-
plant-based. He's been using that plant-based idea. He may have coined plant-based, and then when we were writing the China study, I remember having a conversation about the whole food is just as important.
right.
So we put a awkward dietary name of whole food plant-based in that book, which of course my dad led. So
You guys get credit.
it still has yet to come up with a sexier name. I don't know.
It's stuck. Must be good.
It's good. It's good. Thank you for that. All right, guys. Anyway, it's great to see you all. Thank you again to the panelists. Dr. Sannidhi, you did a great job with that case. I know that's a lot of work to prepare. While the rest of us just get to sit back and enjoy. And Dr. Campbell, thank you so much.
Sure,
Dr.
thank
Vega,
you.
thank you so much. This was terrific. Yeah. Okay. See you all next month. Bye-bye.
Thank you.
Bye, everyone.
Thanks, everyone.